Good afternoon, good morning, good evening, everyone, depending on where you are in the world. Giving it a minute so that we are ready to go. All right, I think we're ready. Hello, everyone. Welcome to our October speaker series. Today's topic is a conversation with a neuromuscular nurse for GBS-CIDP and MMN. We are so glad that you could join us. Today's conversation will focus on this topic specifically, but if you are looking for information outside of what we discussed, please send us a message or an email, and we'll be happy to point you in the right direction to a resource that can help you. Quick introduction, my name is Kelly McCoy, and I'm the Director of Patient Engagement here at the GBS-CIDP Foundation International. I'm so glad to welcome you all to today's session. I would be remiss if I didn't stop to say a big thank you to our sponsors for making this program possible. We truly appreciate your support. We're thrilled to have Hannah Smith with us today. Hannah is a highly specialist neuromuscular nurse at the Salford Care Organization, Northern Care Alliance, NHS Foundation Trust in London, United Kingdom. She brings such valuable experience and insight to our community. Before we dive in, just a quick reminder that these webinars are meant to be educational. They are not intended to provide individual medical advice or to troubleshoot any personal cases, so please always be sure to consult your own physician about your specific care. If you'd like to ask a question, please type it into the Q&A below. We'll get to as many questions as we can, but please keep in mind that we cannot discuss individual circumstances or specific medications. So with that, Hannah, hi. Thank you again.
Hi.
Thank you again for joining us. It's so wonderful to have you. If you're ready, we could get right in.
Yes, definitely.
Perfect.
Nice to speak to everyone today. And
Yes.
yeah, thank you for inviting me.
Yes, thank you so much. And hopefully I got your title correct.
Yes.
You're so accomplished. I want to make sure I get everything right on beat.
Yes. The highly part always makes me feel a bit uncomfortable, to be honest, but it's partly to distinguish between a few of us at the trust. So yeah.
Well, you deserve the distinguishment.
Thank you.
All right, so this going back to some of the questions that we've received in advance, we can get it started so that we could take as many questions as we can.
Mm-hmm.
So starting off with questions about treatment. What are the key differences between IVIG or intravenous immunoglobulin and SCIG, SCIG, or subcutaneous immunoglobulin treatments, and how do you determine what's best for an individual patient?
So I mean, the main difference for us really is that the intravenous method, so that's going in through the vein, and here in England anyway, that needs to be done by a medical professional, whereas the subcutaneous, that goes into the fatty tissue, so typically that's done into people's stomachs, although you can also do that in your thighs, back of the arm, if someone else is going to help you with that. But in most cases, that can be done by the patient themselves, so it offers a lot more independence for someone. It does often need to be given more frequently because you need smaller doses at one time. I would say our average dosing schedule for the intravenous is every 4 weeks, whereas with the subcutaneous, it's every week, sometimes twice a week, dependent on the dose. But as I mentioned, it gives you a lot more independence to be able to manage that treatment yourself. So I would say it's about 50-50 split for my patient cohort. A lot of people have gone on to the SCIG because they want to be able to control the treatment themselves. They want to be able to fit it around their own lives and take it like traveling and things like that with them as well. So it's given a lot of people that freedom back. But we do have people that like having it in the hospital as well. They feel safer. They like the patient group. If they've been coming for a long time, they can make friends and, seeing the same faces every time. For some of them, it adds that social aspect to it. So it does very much depend on the person, really. We do find that there's a bit of a safety angle in terms of choosing patients as well, though. So we've found that the subcutaneous method tends to have a lower side effect profile. So sometimes we will choose to put someone on the subcutaneous because we feel that they're going to have less side effects with that. Especially as patients get older as well, and that their risk of things like blood clots gets higher, we find that we want to try and encourage them to go onto the SCIG where possible. But for the most part, for us, it's about what the patient wants. So we present all of the options to them and then take it from there. We are using the facilitated subcutaneous as well now, where they can do it themselves at home and it's going into the fatty tissue, but they don't have to do it as frequently as well. So we've got a few more options available now with IG, which gives the patient a lot more choice, which is nice.
It's wonderful that they also can make that choice just based on lifestyle, on their own individual needs. That's really wonderful. And
Yeah.
one thing you did touch on, which I would love if you could expand on, is the side effects. What are the common side effects of both IVIG and SCIG, and what strategies can be used to manage those?
So I'll start with SCIG just because I find that there's less. So we do occasionally find that people will get a small headache, feel a little bit tired afterwards, but for the most part, those symptoms seem to subside once they've built up like a tolerance level to the treatment. The more common side effects we see there is that you can often get a reaction around the actual infusion site, and that can be itching, it can be redness, it can be a bit of a bump. We find that when we've advised patients to infuse that slower, then that does tend to alleviate a lot of those kind of infusion site reactions, which is easier when they're using like the push method of administration and they're controlling that flow rate themselves. If someone is using a pump to administer SCIG, then we can try different tubing sizes and that can slow the infusion down as well. So that's usually the common thing that we would do there. With the intravenous, most patients I've found will get a headache after the first 1 or 2 months of treatment. Again, it does tend to ease off as they get used to it. But we would pre-treat with paracetamol, and if necessary, to try and combat that. But it does tend to get easier the more that patients have. We restrict the infusion rates for the first couple of months as well to try and combat that. So it's all done in steps. So it starts very slowly, goes up every 30 minutes, but we actually restrict it at 200 mils an hour for the first 3 months, just because we've found that it lowers the chances of them getting side effects. But another common one is a skin rash. So we don't like to pre-medicate with an antihistamine to try and preempt someone getting a reaction because we don't want to mask it. But if they do get rashes, then we will change the batch or the product brand the next time we give it. And that in most cases solves things. We've got a couple of patients that have then needed to go and have a regular antihistamine just to manage that sort of reaction. But I would say that's the most common one, other than a headache and fatigue, that I come across.
Yeah, and so we did get an audience question relating back because you had mentioned that SCIG may have a lower side effect profile, and they were wondering if you've noticed a lower efficacy with SCIG.
Certainly with some patients, but I can say that I've noticed a pattern in who it's not worked as well for. As I mentioned, we've got around a 50-50 split in our cohort of patients on both, and I'd say that's kind of approaching 100 patients on each. So it definitely works very well in a lot of patients. But yes, sometimes we've found that it's not worked as well for some, and we have swapped back to the intravenous method with those patients, which is always an option. And we say that to them at the beginning as well, that again, it goes back to choice. Even if it's working well, but they just don't find that they get on with it, they might not like injecting themselves, then we let them swap back. I would say that for some patients, actually, the amount of fluctuation in the symptoms that they were getting on intravenous and having it every 3 or 4 weeks, that has gone when they've transferred onto the subcut method. because they're getting a dose every week and we start it a week after the IV, it seems to kind of keep them topped up. So they notice a lot more of a steady state in their symptoms, which for some patients is a lot better as well. So it does vary a lot by person.
That makes sense. There's lower peak and valley
Mm,
in terms of their symptoms from their condition.
yeah.
We did get a question as well about switching off of IVIG and on to SCIG. And I guess they're going to be traveling for an extended period of time, but they want to come home and switch back to IVIG. I guess that's something that they trust and they're used to. Is that something that
Mm.
you would recommend?
We do it occasionally. We try to encourage people to pick one method and stay on it. But I think that's always partly as well down to your healthcare system. And for us with the NHS, we're sometimes quite restricted in what we can do. I think if patients are wanting to switch between dependent on different scenarios, then I'd encourage people to talk to their healthcare providers about it, because as I say, we do occasionally do that for certain patients if they are going to be traveling for an extended amount of time. Obviously, we want to keep them as stable as we can do during that.
Right. And for dosage for their treatment, how long typically does it take to kind of figure out, I like to call it a choreography, but find the right dosage and schedule for treatments?
I'd say it takes at least, for most patients, it probably takes us up to a year, I would say. We've got those initial treatment doses at, your 2 gram per kilogram dosing. That's how we do it. We'd give that for 2 to 3 months to kind of see that really good effect, and then we would try and wean down. We go in 20% increments in my trust. So if we hit an increment where we do start to see a deterioration, we kind of know where to go back up to. But I'd say that takes us certainly at least 6 months to try and get down to a minimum dose at that time. And then we will look at changing the frequency if we've not seen too much fluctuation as well in the symptoms. Or, if we're seeing a big drop off in someone's symptomology after 2 or 3 weeks, then we would give it sooner. We tend to go for 4 weekly as an average starting point and then go from there. But yeah, I think it probably takes us about 12 months usually to try and find that dose and frequency that we're going to stick with for a longer term.
So patience, and
Yes.
hopefully you'll get there.
Yeah, and it's quicker. It's quicker with some patients than others as well, and I think that depends on how motivated sometimes they are to get off treatment, and because some of them don't see it as a long-term thing, and kind of, which it might not be, but they're quite motivated to get it down as low as they can as soon as possible.
That makes sense. Someone actually asked, what do the saline flushes do before IVIG?
So if it's usually just to make sure that your cannula is working. So it just makes sure that it's the fluid's going into the right place, essentially. Although it does provide you with a bit of extra hydration as well. If you are being given some places will do small amounts, some use larger, but if you're being given a larger amount of saline, then that's adding some extra hydration as well, which can also alleviate some of the side effects that you can get with IVIG.
Great. We love the hydration. That's the key.
Definitely. Definitely a good one for the headaches, actually. That's the one thing I will tell all of my patients is drink extra the days before, of, and after your infusions, just to try and alleviate some of that. And it definitely helps.
It helps with the headaches and helpful.
Yeah.
Great. So for patients that are non-responsive to standard treatment, such as IVIG, what other options, I know we talked about SCIG, but what other options might their neurologist consider, and what role does the nurse play in monitoring that?
After immunoglobulin, at the moment, for us in England, we've not got access to any of the newer treatments, unfortunately, although we're, keeping our fingers crossed for maybe next year. But if they're available, then obviously that I think would probably be the next step in a lot of cases. If they're not, or if the neurologist doesn't maybe think that they're suitable, I think the next step would probably be looking at immunosuppressant medications instead. So things like we might try oral immunosuppressants, so things like mycophenolate, or occasionally some of the intravenous ones as well, like rituximab and cyclophosphamide have both been used in my trust. Definitely not often. We usually try and push the IG dose as high as we can before we look at swapping to something else. But that, I think that might change if we get access to some of the newer drugs which are becoming available, which is very exciting.
That is exciting. We love that. I mean, I've been with the organization for 10 years, and when I started, there was one available treatment. And now there are many. So the horizon is looking bright in terms of landscape. So what should patients do if their symptoms seem to reappear or worsen between their treatments?
Definitely contact the nurse if you've got one with your healthcare provider. I think that's, for us, that's one of the main aspects of the role, really, is that like day-to-day management. The neurologists are, you know, very busy with clinics and things, and they can find it hard to really tailor someone's treatment to them, whereas we tend to, you know, the neuromuscular patients and the immunoglobulin, that's kind of one of our sole focuses. So we've definitely got more time often to do that. So definitely get in touch with whoever it is that you've got at your healthcare centre. If it's that symptoms have been quite steady on a certain dose for quite a while, but then suddenly seem to be getting worse, then we would work with the patient to try and figure out why that might be. Sometimes it's that they've had an illness, a bug, they might have had a vaccine, something like that, that's exacerbated symptoms. So we might not need to make changes to the treatment plan. It might be that they need a short course of steroids occasionally. So we will try and figure that out with the patient. If there's not a reason that we can pinpoint, then that's when we would look at changing treatment doses and see if there's anything else going on as well that's underlying that maybe we've not kind of picked up on yet.
And what is the nurse's role in the coordination of patient care? So including the administration of medication, scheduling of that, communication with the neurologist. You play a big role, I know that.
Yeah. So at my centre, I do all of the prescribing of the immunoglobulin. That's going to vary dependent on whether people have got the prescribing licence as a nurse, but it's certainly an aspect that a lot of my colleagues do around the country as well. So we typically are not involved in the day-to-day scheduling, but if we are changing someone's treatment regime, then we would be in contact with the infusion unit to make sure that that is done. So, you know, say we're changing from 4 weekly to 3 weekly, or maybe adding on an extra day to try and spread the dose out a little bit more. The other aspect, I would say, especially if people are doing SCIG at home, or we do have a couple of patients having IV at home as well. So that's very much about liaising with the home care companies that we use to make sure that the deliveries are being done on time, or if nurses are going in, that that's all organised. So there's a lot of paperwork for us to send off there, and then we receive feedback from those healthcare companies as well on a regular basis, especially if they're going in and treating the patient, to say that everything's been stable. And then making sure that we're staying on top of reviewing patients as well. So we like to try and see everyone every 3 months if we can do in a set clinic appointment, if we're not seeing them on the infusion unit in between as well. And again, especially if they're having that treatment at home and we've not got that contact with them, we want to make sure that their objective measures like grip strength and balance and things like that are stable, and that we're giving them the right dose, really.
And we have a lot of questions on treatment, which is great. Everyone's very interested, especially about regards to IVIG and SCIG. Someone had asked what is actually involved in transitioning from IVIG to SCIG. And you did touch on this a bit, but if you wouldn't mind breaking it down.
Yeah, of course. So we like to have had someone have the last IV dose a week before they transition to SCIG. So the idea being that we're giving them that big boost of immunoglobulins, and then when we transition then to what's a smaller dose, but going to be more often, that we're kind of keeping that level topped up, rather than, let's say someone is having their infusions every 4 weeks. We don't want a 4-week gap before they start SCIG, because you're then starting from the bottom essentially and trying to top that back up again. So that's the first thing, is getting the timing right. In terms of the training that's involved, so depending on the healthcare centre, they might train patients in-house, or use a home care provider. We do a bit of both because we give that choice to the patients basically. They can either travel to us for the training or they can have it at home. But you aren't just given the equipment and the medication and kind of told, this is what you do, crack on. We have like a list of competencies, kind of the same way we would train another nurse, really. We want to make sure that you know that you're doing the right thing, you're doing it safely, you've got all of the cleaning down, and that it's going to be done the same way that we would do it. So all of that is gone through, and as many sessions as it takes to make sure that you feel comfortable, that's how long you would get. It's not a set amount for each patient. It's very individual.
That's wonderful.
And then there's all of that paperwork obviously involved as well with getting the prescriptions and the equipment and things. But that's typically delivered to the patient at home as well. So once everything's set up, they don't need to be coming to a hospital or an infusion centre to be picking things up and picking up prescriptions. It should all just be done and delivered to the house, and they've then got that freedom, as we talked about before, to fit it around their life.
That's wonderful, and so convenient, hopefully, to patients that are able to self-administer. Is there more significant monitoring or blood testing involved if you switch to SCIG, or is it very similar to IVIG?
It's very similar. I think everywhere does slightly different blood monitoring in terms of frequency. We've recently switched at my trust from 3 monthly to 6 monthly because we found that, we didn't need to be doing it every 3 months, but we still would like to see patients in clinic appointments every 3 months. If someone has transitioned, we will see them earlier than that because obviously we want to make sure that they feel comfortable with what they're doing, but also that it is keeping the condition stable, because there are some that we mentioned before it doesn't work as well for. If someone's been on the same dose for quite a long time, we will start looking at not having to see them as often, which usually by that point they're happy to do as well. So we might transition to every 6 months. We would typically see the patient that often, with the neurologist seeing them less frequently, but in between, so that they've had contact with both of us.
Wonderful. All right. Well, somehow we're out of the treatment section of our conversation. We're on to managing daily life. But our number one question here to get us started would be, what are the key differences in the progression of symptoms of GBS, CIDP, and MMN? And that is a loaded question, I know.
Yeah, so generally speaking, GBS is going to be a very quick progression. So usually I think it's that it would be within 4 weeks. And once treated, whether that is with steroids, plasma exchange, immunoglobulins, the patient should improve, and then usually will require some rehabilitation as well, but they should not get a repeat episode. If that were to happen, then that's when we start to look at maybe there is a bit of a crossover there and it is more of a chronic picture, and more CIDP-like. CIDP and MMN a lot more insidious, so that can start with maybe someone notices a little bit of tingling in the fingers but doesn't really think anything of it until, it might be 2 years later that they start to notice that they've got weakness. So it does tend to usually come on a lot slower and over a longer period of time, with both CIDP and MMM. And then the treatment for that. So, sorry, I was just thinking back to what I said with GBS. So recovery with GBS, we'd said, it's treatment and then recovery and looking at rehabilitation. But obviously with the CIDP and MMN, it's in most cases then going to be a longer treatment span, where before we might then look at whether or not we can take someone off treatment and whether they need that anymore.
And then how would someone be able to kind of distinguish between this is normal progression of my condition, or this is a possible relapse or reoccurrence for GBS patients?
I would say it kind of goes back to that speed of which the symptoms appear. So hopefully if we're giving someone the right treatment at the right dose, then we shouldn't see much progression. So we might find that as people age, a lot of people as we age, we're going to get a little bit weaker anyway. So that on top of something like CIDP, we would still expect to see maybe a loss of strength. But it should be, let's say if we were talking about hand strength, it should be, a couple of kilograms a year potentially and not be anything drastic. Whereas if it is a relapse, it's going to be quite sudden, a sudden loss of function or a change that has happened regardless of treatment. And then same with GBS as well. If it is a relapse of that, then it's going to be that quick sort of recurrence of symptoms. Although if someone did notice changes and had previously had GBS but had a slower appearance of symptoms, then I would still encourage them to get that looked at because maybe it is something that's evolving into a bit more of a chronic condition.
And what would trigger someone to say, okay, it's time for me to seek emergency medical attention?
I think especially thinking about GBS, if someone is having any problems with the breathing or swallowing, definitely straight to emergency care. Or anything that is not typical for GBS or CIDP or MMN. So any kind of central nervous symptoms, so changes with like bladder and bowel are not typically associated with these conditions. So I think sometimes patients think that maybe that it is related and don't mention it for a while until the next appointment, but that's usually something else. So I would encourage people to go and get care with relation to those things as well quite quickly.
Yeah, the foundation, we refer to that as the proverbial trash can, and we urge patients to not put everything in the GBS-CIDP or MMN trash can, to kind of maybe mention everything, because as you said, sometimes they're often non-related and they do need immediate medical attention.
Yeah, and I think because the conditions are so rare as well, although it doesn't seem like it when you deal with them so regularly, but they are, and a lot of healthcare professionals will just potentially assume that some of the symptoms they go to that person with are probably related to the CIDP or the GBS or MMN, and that's often not the case. So I'd say if it's ever something that maybe doesn't feel that urgent, but they're not sure, then just go back to your neuromuscular kind of specialist and just double check that before kind of brushing it off as, oh, it's just part of my condition.
Yeah.
As you say, not putting it in that trash can.
Don't put it in the trash can.
Yeah.
And how can a patient expect their condition to change over time? And is it possible to go into remission?
We like to try and see if patients will go into remission in most cases. It's because we've not got a kind of marker of whether these conditions are active yet, then the only way we've got usually of seeing if the condition is still active is pausing treatment for a short time, which is quite scary for most patients because they've come to rely on the treatment. But I think if you with the right team, then we don't kind of stop the treatment and leave it there. We will make sure that we're regularly checking in and also that we've got access to set that treatment up again quickly if we need to. But it is kind of the only way really that we can see if that condition is still active at that time. I think it's sometimes we can get a bit of a hint on terms of how long the symptoms were present before we met that person or how long before we started treating them. If they were fairly maybe say they came on over a year or 2 years, then sometimes that indicates to us that maybe we will be able to see a remission sooner. I've also had patients where they've had a remission and they've been off immunoglobulin for 10 years and then the symptoms have returned 10 years later and they've come back and been on immunoglobulin. So it very much varies by patient, but it can happen definitely. So it is always worth a try and just seeing really. It's just a wait and see kind of thing, I think.
Wait and see, yeah. Back to that choreography of treatment and seeing how long you can go.
Yeah,
are there any lifestyle changes or precautions that people can be doing or that they should be aware of as their condition progresses?
I think in terms of things that might worsen symptoms, so a big one that we come across is like viral illnesses and things like that, and vaccines as well. They can always trigger or often trigger a bit of a relapse in symptoms occasionally. So I always advise patients that, do get your vaccines, but try and time them so that they're right in the middle of your treatment. So if you're having 4 weekly infusions, get them at 2 weeks, just because we find that tends to balance things out a little bit. It's not an immunosuppressive medication. Your immune system is not worse than anyone else's, but if you do catch something, it may make your symptoms worse. So it's always worth being a little extra cautious around anyone else that you know is unwell. But for general lifestyle, I think, I think it probably varies in different countries, but definitely here in England, I think we have got almost a bit of a reliance on the treatment sometimes, and I think we can forget that there is things we can be doing as well. So I talk to all of my patients about how important exercise is. If we've got this thing that's making our muscles weaker, then the more strength we can have in those muscles as a baseline, then the better we're going to be if we do get a relapse. So I encourage all of my patients to do some sort of resistance training within their abilities. And, we would work with physiotherapists as well to try and get a tailored program for them. And then it's kind of the general wellness stuff. So, exercise, eating healthily, getting enough sleep, all of those things improve your health, which will reduce the amount of inflammation potentially, and then lower the impact of something like CIDP on the body. So if someone can target all of those things and try and get those the best they can do, hopefully they'll have a lot less of a symptom burden. And we may then be able to lower treatments as well. I've seen sometimes if someone's been able to get the blood sugar under control, for example, if they've got diabetes as well, that we've then been able to lower the amount of immunoglobulin they've needed further down the line. So it is about looking at those other things and looking at the health holistically.
So addressing comorbidities, yeah, that's something that I think a lot of people don't even consider. We did have a question about pain issues with Guillain-Barré, and is there a treatment or something that they could do to help mitigate their pain?
So a lot of patients will end up on some sort of medication for pain, I think, with GBS. So if they've not been started during that first admission and onset of the condition, it's things. There's often sort of a bit of a ladder there around these types of medications, but neuropathic pain medications are things like amitriptyline, duloxetine, gabapentins. Those sorts of things are useful, but if the dose would usually be kind of ramped up and titrated upwards, but we don't want someone to hopefully need that high dose forever. So it is making sure that at regular timings you're trying to wean yourself off those as well. Depending on the type of pain, if it's persisting, topical treatments can work quite well as well. So either heat with things like capsaicin, so like chili. There's creams, there's patches as well now for that, which can be quite useful. Or sometimes like the opposite, so menthol creams can sometimes bring like symptomatic relief in like the short term as well. Same with like warm water, cool water. It's almost like distracting your body from that pain by giving it another sensation to focus on.
I've heard about the hot pepper, the pepper and the menthol, but tricking your brain is interesting. So you recommend like doing hot and then cold, sort of shocking your system?
Yeah, kind of like almost seeing which one, because I find that some work best for other patients than, some patients get on well with like the chili creams, whereas some don't find that useful at all, but have found a lot of relief from like a menthol type cream. And yeah, if capsaicin creams do work for people, there is it does have to be applied by a healthcare provider, but there is something where it's in a patch now as well that's a bit more longer lasting, if the pain is quite persistent. But definitely, if someone's finding that they've been tried with some of these neuropathic pain medications and they're not really finding that they're working, there's usually a lot more available than what would first be offered. So I'd speak to your kind of neuromuscular specialist about seeing a pain specialist as well if it's something that's ongoing, because you often will need that other speciality to get involved as well.
Yeah, I always recommend pain specialists just because they
Yeah.
understand it better than anyone.
Yes,
Um,
definitely.
we did get a question, which I've been asked this a fair amount, so I'm so interested to hear what you say. But in terms of lifestyle, drinking
Mm,
alcohol,
mm.
um, occasional drinks, is that okay if you have GBS or CIDP?
Yeah, it's that we would still recommend staying within those limits that, we get told. So it's like 2 units a day and things
Mhm.
like that. It's not going to cause any harm to have some alcohol, but take note of how that makes you feel. If you
Mhm.
have a few drinks and the next day one of your symptoms feels worse, then, maybe either don't have that much again, or it might be that, you kind of have to plan that in, because you might, if drinking's quite social, isn't it? If,
Mhm.
you don't want to necessarily restrict yourself if you're going to like a wedding, you want to be enjoy a glass of champagne with your family. But, if you do notice that that makes symptoms worse the next day, then it's just about planning that in, and being aware of it really. But I definitely don't kind of put people off. Although I would say if, with immunoglobulin treatments, maybe
Yeah.
don't drink on the kind of days around those, because it kind of again goes back to that hydration thing, but it can be dehydrating to drink alcohol, and it can definitely make the side effects of immunoglobulin treatments feel a little bit worse, especially
Yeah.
the
So
headache.
risk versus reward, but
Yes.
life is hard. Have a drink
Yeah.
here and there.
Yes,
Just do it
exactly.
responsibly.
Yeah.
That's a
Yeah,
wonderful
exactly.
answer.
It's definitely not a complete no. But yeah, just being responsible really and seeing how your body reacts to it.
And not right around your infusion when you should be drinking as
Yes,
much
that's the one time I
water
would
as
say
possible.
definitely not. Yes.
Perfect. So going into some general and personal questions, we actually got one which was asking, this is from the audience, if there's any
Mm.
advice on dealing with the psychological impact of having a chronic disease or something like
Yeah.
these conditions.
I think it's, I mean, psychological like support can be quite hard to come by, especially that's really tailored to someone having a neuromuscular condition. But
Mhm.
if it is available and you do feel that you're struggling, then definitely ask if that's something you can be referred for, because
Mhm.
everyone's going to react very differently, but some people do find it a lot harder to adjust than others. Um, and, clinical psychologists, neuropsychologists can help work through that. Um, I think if it's that it's just the initial shock, then, speaking to your healthcare professionals, but also reaching out to obviously places like yourself, the charities that are available and
Mhm.
peer support groups and things, getting other people's lived experience can be really helpful, because it can feel quite scary, and speaking to people who have been through it can really help you figure out where that's going to fit within your life. Um, but if people are struggling with that diagnosis and are not able to access sort of specialist support, then I would still try and seek out your more general psychology input if you can do that, even if it is seeking that out online. So things like
Mhm.
um, computerized, like cognitive behavioral therapy can be
Mhm.
helpful if it's just basic support, where, you know, that does tend to go through things like getting good sleep and sort of challenging negative thoughts and things like that. But that sort of stuff can be quite helpful for some people if they've not kind of come across that before. But always just mention it to someone, whoever that is. And, if it is your healthcare professional, they might be aware of something that they can point you to that will help you through that time.
Thank you for calling out our organization. We do offer peer-to-peer support. So if you wanted to talk to someone going through the same journey as you here at our organization, as
Mm,
well as on your neck of the woods, Hannah, IN, formerly known as GAIN, also offers
yeah.
peer-to-peer support. We're always here to help in any way. We also have a clinical licensed social worker on staff who can help offer you some mental health resources, but definitely it's great that you recognize that you might need some emotional support. Please seek that out. It's
Mm,
very important in the journey.
yeah.
Um, so what is the nurse's experience working with patients, inpatient, outpatient, who have GBS, CIDP, and MMN?
Sorry, it just cut off slightly there at
Oh,
the end. Could you repeat the question for me?
yes, yes. Can you hear me okay?
Yes.
Okay, perfect. So what is your experience working with patients, both in an inpatient and outpatient setting that have GBS,
Yeah.
CIDP, and MMN?
Um, so for my trust anyway, the patients who come into the neurology unit with GBS, we typically don't have a whole lot of interaction with as the neuromuscular nurses. We might get involved for certain patients, but for the most part, they receive care on the ward by the doctors, the physiotherapists, the nurses there. And if they are then kind of going through rehabilitation and then don't seek future help because they don't get a relapse, then we don't tend to come across them often. We are looking with kind of having to increase staff numbers as well in trying to offer a bit more support through that time though where that diagnosis has been given, more for the social side of things really and signposting to organisations and things like that. Um, for the patients who have got CIDP and MMN, that we're definitely there for, the whole of that treatment journey, and we get to know our patients really well, I would say, because we do have such regular contact with them. But we'll be there, if they're diagnosed as an inpatient, which occasionally does happen, then we will be there at that time. And usually around transitioning as well from getting immunoglobulin treatment as an inpatient to an outpatient, we'll be really involved with that. I find that often if they're given the diagnosis as an outpatient, then depending on the trust, again, sometimes the nurses will actually be sat in the clinics with the neurologists, but my clinics are separate, so I will get an email or a referral from the neurologist I work with, letting me know that a patient has got CIDP or MMN, and I will then be the one that initiates them on treatment. So I then book them into a clinic where, I get an hour to sit down, go back over the diagnosis in case they don't understand something or they've got questions. Then we go into the treatment, how it works, what the side effects are, what they can expect. And then we'll do some things like objective measures so that we can kind of measure progress. But I always make sure we've got like a good hour at that initial appointment. And then after that, and this goes for people who've been an inpatient as well, but we see them 2 weeks after each infusion to make sure there's not been any side effects we need to do something about and to make sure that they're progressing the way that we want them to. So we do have very regular contact with them.
That's wonderful. And in that initial appointment, is that where you would discuss sort of long-term disease management with the patient and their family?
Yeah.
And how do you approach that with the patient?
Yeah, so it's a question that usually comes up, and if it doesn't, I do put it in there myself, but a lot of patients will ask, is this going to go away? Am I going to be on treatment for the rest of my life? And that's when we talk about, it's very, very individual, but I will give a few examples of different patients to sort of say, like, here's the spectrum that we're working with. And then because most patients will start on intravenous immunoglobulin, I do also at that point talk about having it at home or doing subcutaneous treatments so that I think for some patients, especially I find the younger patients, it's quite daunting to think I'm going to have to come to the hospital every month for the rest of my life for an intravenous therapy. So I like to manage expectations early by saying, yes, this is what's going on at the moment, but there's options for independence with your treatment further down the line when we get to a bit more of a stable state. And I think that comforts people and, relieves some anxieties at that first appointment. And then we will touch on the exercise, the diet, and that sort of stuff as well. Kind of linking it to the recovery, really. So I talk to them about, for example, maybe if they're able to eat in a bit more protein, because that can support kind of cell repair. Once the immunoglobulin's working, maybe at that point we would refer them to physiotherapy and make sure that they're getting some sort of exercises in there as well to boost that recovery period and progress things quicker. So I do touch on a little bit of everything really at that first appointment.
And you had just mentioned this, maybe you could just expand on it a little bit for us, as you had mentioned the protein and the physio and the exercise. There was a question from the audience about, is there a way to restore or regain muscles that have atrophied?
With these inflammatory conditions, it does depend on the amount of nerve damage. So you've got the demyelinating damage, which is like in the name of CIDP. So that's where the damage is just to the myelin sheath, so it's like the wrapping around the nerves. There's holes within that can be repaired. If it's progressed to axonal loss, which we do sometimes see, then that's often, where the nerve itself is damaged, and that's quite difficult to get back. So in terms of the muscle, then, if we can repair that nerve damage, then the muscle can be rebuilt. It might be quite a slow process, but there is stuff we can do with that. But it does very much depend on the amount of nerve damage that's there, and whether we see that repaired in what time scale. Sometimes I would say there's a difference in that with the CIDP and MMN patients as well. It's sometimes a bit more difficult with MMN to recover some of that muscle function, but there's usually things we can do to at least regain a little function, if not all of it. And also, even if it's not that we're improving things, we can at least make sure that they're not getting any worse with exercise. Yeah. So I would say, even if you don't necessarily feel that it's doing something, it's still really important, because it will be keeping the muscle function going that you do have.
Maintaining it at that point, making sure you're not losing any. Yeah. Are there any subtle symptoms that people should be watching out for that they could inform their clinical decisions?
I think there's a bit of a balance with it, because some of them are so subtle that if you start to look for them too much, you can get really obsessive over it.
You drive yourself. Everything will become a symptom.
Yes, exactly. But some of them are things that all of us will experience from time to time. So one of those I would say would be fasciculations, so like twitches in a muscle. If I'm really tired and I've not had enough sleep, I will get a twitch in my eye. That is just part of our nerve function. But with MMN, CIDP, any sort of kind of beyond the normal, I would say fasciculations and twitching mention. And even if you're not quite sure if maybe it is normal, it is worth mentioning anyway. But I'd say that's definitely something to look out for. And any changes in sensation, really. So whether that's that, maybe you've got numbness and it currently comes up to kind of mid calf, but then it feels like it's creeping up towards your knees. That's the sort of thing that we're looking at, really. Or any changes in the intensity of sensations as well. And that goes for when people are starting treatment. Sometimes they've got numbness in their hands, but then it changes to pins and needles and it's a bit more intense. But sometimes that can actually be kind of, as it's improving, it's gone from numb to painful before it gets better. So it's all relevant, but it's all going to mean different things for different people, I think.
You actually just touched on a question I was going to ask, which is increased pain always a bad thing, or is that a sign sometimes that you may be getting better?
Yeah, it is. And it isn't always, but definitely kind of early on in treatment, I think I've found that it is often a sign that kind of nerves are repairing themselves. They start to misfire because, they're just, I always think of it as they're not quite sure what they're doing yet. They're just kind of getting back on their feet. So they can start doing, they can start doing some strange things sometimes. So it is sometimes just a sign that things are getting back to what we, more towards what we would call normal, especially if they've been completely numb and then gone to pain. I think of it as kind of going backwards through that symptom pathway.
We've somehow already arrived at our last question, unless the audience sends us any more, but it's a good one. It's what are the most effective ways for me to communicate my needs and my concerns to my healthcare team?
If you've got an appointment, come with your questions written down, because a lot of people will forget them. I think it's something that we try not to have be there, but there's always going to be a little bit of a power dynamic, I think, between a patient and a healthcare professional in a lot of cases, because patients will see us as the people holding that knowledge and the answers. So there can sometimes be a feeling of nervousness, or especially if you've not met us before, you might completely forget. There's obviously a lot of information we're throwing at people as well when we first meet them, or even further down the line. So I think coming up to appointments, writing down any questions that you think of, bringing someone with you if you can, because maybe they remember something that you don't. and also in terms of listening to what we're saying as well, they might pick up on something that you miss and vice versa. So you can kind of compare notes, I guess, after the appointment with that person. One of my patients at the moment has his own dynamometer, so for like measuring his grip strength in his hand. And he does that very regularly, and he's kind of mapping it to when he has his treatment. So that's really useful because he brings it as a graph, and I can see, even though I've not seen him, I can see how his grip strength has changed. He's got MMN, but I can see how that's changed with his treatment. And when we've reduced his dose, I can see that that's had an effect. So we need to put it back up again. So that's, maybe not everyone's going to be able to do that, but it is that sort of thing that can be really helpful to kind of come prepared with what you've noticed. Do you think that your treatment is maybe not lasting because, you feel that your symptoms reappear, let's say 6 days before your next infusion, or maybe it's only a day? Those kind of things are what we're looking for when we're deciding on whether we need to increase treatment frequency or whether we can prolong it and things. So, treatment diaries can be really helpful for things like that, when you've had your treatment and then what kinds of symptoms you get. Same for looking at side effects. Going back to like skin rashes and things, sometimes patients will get that immediately, but they might not get it for a week or two, but it's still quite important to know when it's happened and if there was something else that might have triggered that as well. So those kinds of things can be really helpful to kind of get the most out of an appointment, especially if you feel that those appointments, because everyone, I like to try and set mine so that I've got enough time, but if they are quite rushed, you can feel like you need to fit a lot into them. So if you come prepared, then you kind of get the most out of it and will get what you want out of that appointment then.
And write down dates, right? Like if you took a fall, write the date, because like you had mentioned, a lot of patients are seeing their care team every 3 to 6 months. And you might think, oh, that maybe happened a month ago and it was 3 months ago, or vice versa.
Yeah. And then maybe you can't remember whether it happened a few days before your infusion or a few days after. That sort of stuff's important, because if it was before, then, we might be expecting that a little bit more. Whereas if it was a few days after, we wouldn't necessarily expect it to happen if we were treating at the right dose. So yeah, anything like that, dates and dates of infusions kind of all mapped together are really helpful.
We did get an audience question, which says, do you find that patients in our space with our conditions also have other problems or polyautoimmunity? So this actually mentioned spinal stenosis, Lyme disease, heart issues, DVTs, etc. If so, which ones are popular?
I'd say we do occasionally see a bit of a link there with things like diabetes, which can be quite difficult as well because you can get neuropathies with diabetes. So that's quite hard unpicking which symptoms are related to a diabetic neuropathy and which are related to CIDP. So that's something that I see quite a lot in my patients. I'd say as patients get older, then, in anyone, risks of things like DVTs and heart conditions go up. So I don't know if it's necessarily kind of a link there that's if you've got CIDP, then you're more likely to get a heart condition. But I think it's about our kind of aging population and just I feel like at the moment most people end up with some form of illness in later life, don't they? So I guess you do end up kind of seeing all these sorts of comorbidities. But we do know that immunoglobulin can have an effect on like thromboembolic events and increased risks of clots. So potentially sometimes it is unfortunately down to that as well. But it can be really difficult to unpick because there's just so many other factors that are involved in all of that and increasing risks.
Well, thank you, Hannah. That was our last question. Do you have any words of advice for our community or anything you'd like to share?
I think definitely like kind of, I guess, key takeaways from the stuff we've talked about, if you're going to be going on immunoglobulin treatment, stay hydrated. It's definitely the one that people will miss. And as mobile as you can be as well. I always advise my patients. It kind of mitigates, I think, some of that risk slightly of increases. of blood clots. Although we don't see them often, it's just the side effects that I guess as
Yeah.
healthcare professionals we're a bit more concerned about. But yeah, I think trying to try and kind of be the expert in your own condition. So as we talked about there, if you can note things down, it's really helpful. It helps you kind of get a hold on what's going on as well and feel prepared and have a bit more ownership over what's going on really. I always want people to be as independent as they can be in managing things, even if that is that they're coming to us for infusions. There's still a lot that patients can do when they're at home. So things like the diet and exercise and making sure that if you're not getting offered physiotherapy, for example, that you
Mhm.
seek that out. So, any of the things that maybe you see other people getting access to, if it's not been freely offered, then just ask, because it might
Yeah.
just be that at your centre they've maybe not thought to mention it, but it is available. So just, you can only get a no. That's kind of worst case scenario, but if you ask, you don't know for certain until you do. So yeah, just ask about anything that you're not sure of. I always say there's no stupid questions in healthcare because, everyone's coming from a different starting point as well. So yeah, just ask away at any time
Yeah.
of your healthcare professionals and, your peer support as well, if
Yes.
you're not sure about anything.
Advocate and ask.
Yes,
Or maybe the
definitely.
reverse. Ask and then advocate.
Yeah.
Wonderful. Well, thank you so much, Hannah, for sharing your time and expertise with us
Oh,
today.
you're very welcome.
Thank you to everyone who joined us in this conversation, who submitted questions. And I'm so sorry if we didn't get to your question. If you would like more information or support, please don't hesitate to reach out to us at the foundation. There's some information on the next slide with our email address. You could call us at the office. We're always here to help you connect with the right resources. And once again, a big thank you to our sponsors for making sessions like this possible. We hope that you'll join us again for future programs in our speaker series. But until then, take care and be well. Thank you so much. And
Thank
thank you,
you.
Hannah.